Research and clinical insights provided by Abdullah Al-Ghamdi, MD. Malignant hyperthermia, or MH, is a life-threatening autosomal dominant pharmacogenetic disorder. It aggressively disrupts the normal excitation-contraction coupling process within skeletal muscles, turning routine anesthesia into a lethal event. The crisis originates at a precise anatomical location, the myocyte's sarcoplasmic reticulum. Under normal conditions, voltage-gated channels communicate with the type 1 ryanodine receptor, or RYR1, to regulate the release of calcium ions required for muscle movement. RYR1 is the primary calcium release channel in skeletal muscle cells. In susceptible patients, exposure to halogenated volatile anesthetics or the depolarizing muscle relaxant succinylcholine causes a catastrophic malfunction. These triggering agents lock the mutated RYR1 channel in an open position, forcing a massive, uncontrolled efflux of calcium into the cytosol. The muscle fibers are locked into a state of sustained contraction. This forces a massive consumption of ATP, adenosine triphosphate, the cell's primary energy currency. As ATP is depleted, the myocyte enters a severe hypermetabolic state, leading directly to cellular breakdown, or rhabdomyosis, and profound mixed acidosis. This unchecked cellular machinery rapidly produces lethal amounts of carbon dioxide and heat. The myocyte is essentially cooking itself from the inside out while flooding the bloodstream with toxic byproducts. Because this genetic anomaly turns standard life-saving anesthetic agents into a fatal hypermetabolic trigger, clinical survival relies entirely on identifying the risk early and executing emergency protocols with absolute algorithmic precision. The classic epidemiological profile of an MH patient skews heavily toward young males. However, the genetic mutations responsible for MH display incomplete penetrance. A susceptible individual may undergo multiple surgeries with triggering agents without incident, only to suffer a full-blown crisis on their third or fourth exposure. Consider a documented case of an 82-year-old female patient undergoing a transcatheter aortic valve replacement, or TAVR. TAVR is a minimally invasive surgical procedure used to replace a narrowed aortic valve that fails to open properly. She had a history of multiple uneventful surgeries under general anesthesia, presenting 0 red flags in her preoperative profile. 50 minutes after the cessation of the volatile anesthetic sevoflurane, and well outside the standard intraoperative window, she developed acute respiratory distress, exhibiting extreme diaphoresis and severe refractory hypertension in the recovery unit. This postoperative ECG shows an absence of acute ischemic findings or specific indicators that could explain her constellation of hypermetabolic symptoms. Standard monitoring tools registered the physiological deterioration, but they failed to provide a clear, immediate diagnosis for her acute distress. Because MH violates epidemiological expectations and can present postoperatively in elderly patients with no prior history, clinical survival requires universal vigilance. Physicians must rely on early metabolic indicators rather than relying on strict patient profiling. Preoperative risk stratification relies on successfully differentiating true malignant hyperthermia susceptibility from other congenital myopathies. The anesthetic approach depends entirely on an accurate diagnosis. This table contrasts conditions that carry a direct MH risk, like central core disease and King-Denborough syndrome, against myopathies that carry the risk of anesthesia-induced rhabdomyolysis, or AIR. Conditions carrying an AIR risk include Duchenne and Becker muscular dystrophies. Both profiles require a trigger-free total intravenous anesthesia, or TIVA, approach. TIVA is a technique of general anesthesia using a combination of drugs given exclusively by the intravenous route. However, AIR lacks the hypermetabolic component seen in MH, which drastically alters how a crisis is managed if triggered. Once a susceptible patient is identified, the focus shifts to the operational reality of preparing the anesthesia machine. All volatile agents and succinylcholine must be completely removed from the workstation. Traditional machine preparation relies on high-flow oxygen flushing. On modern, complex anesthesia workstations with internal plastic components that trap anesthetic molecules, this standard flushing protocol can take up to 104 minutes to achieve safe levels. Activated charcoal filters, or ACFs, are now the modern standard of care for machine optimization. These ACFs are specialized devices that capture and permanently hold volatile anesthetic molecules on a highly porous surface. By placing these filters on both the inspiratory and expiratory limbs of the breathing circuit and flushing at 10 liters per minute, volatile anesthetic concentrations are reduced to under 5 parts per million in less than 90 seconds. Implementing ACFs shifts the preoperative focus from hours of operational downtime to establishing an immediate, guaranteed trigger-free environment for the patient. The primary intraoperative diagnostic challenge is that the early signs of MH closely mimic common, less severe crises. A physician might easily misinterpret the initial physiological changes as inadequate analgesia, iatrogenic overheating, or laparoscopy-induced hypercarbia. This simulated capnography monitor shows the absolute earliest and most sensitive indicator of an impending MH crisis, a sharp, persistent rise in end-tidal carbon dioxide, or EtCO2. EtCO2 is the partial pressure of carbon dioxide at the end of an exhaled breath. Crucially, this rise occurs even as the ventilator aggressively increases minute ventilation. Secondary early indicators include unexplained inappropriate tachycardia and masseter muscle spasm, a rigid locking of the jaw, immediately following the administration of succinylcholine. One of the most dangerous clinical misconceptions is waiting for a spike in body temperature to confirm the diagnosis. Hyperthermia is a late, highly morbid sign, indicating that massive systemic cellular damage has already occurred. Relying on a rising temperature for diagnosis is a fatal trap. Clinical intervention must be triggered purely by unexplained metabolic acidosis and a rising EtCO2. At the first suspicion of a crisis, the team must execute immediate, simultaneous actions. Cease all volatile agents, stop succinylcholine administration, and call the MH emergency cart. The respiratory protocol must shift instantly. Abandon the triggering agents and hyperventilate the patient with 100% oxygen at fresh gas flows of at least 10 liters per minute to flush out the volatile anesthetics and combat the profound hypercarbia. The definitive, life-saving pharmacological intervention is dantrolene. Dantrolene is a postsynaptic muscle relaxant that aggressively binds to the RYR1 receptor, physically snapping the calcium channel shut and halting the hypermetabolic cascade at its source. The initial administration protocol requires a rapid intravenous bolus of 2.5 milligrams per kilogram of body weight. This dose is repeated every 5 to 10 minutes until EtCO2, muscle rigidity, and heart rate plummet to safe levels. Speed of administration is dictated by the formulation available. One vial of generic Dantrium requires 60 milliliters of sterile water and significant time to reconstitute, whereas the newer Ryanodex formulation requires only 5 milliliters of sterile water, drastically accelerating delivery. Severe reactions are highly resistant to treatment. These cases may require massive cumulative doses exceeding 10 milligrams per kilogram before the clinician regains physiological control of the patient. Survival is entirely dependent on the flawless, rapid execution of this specific pharmacological blockade before the cellular damage becomes irreversible. While dantrolene stops the calcium leak, it does not instantly reverse the devastating downstream systemic damage. The hypermetabolic fallout continues to threaten the patient's life. The most immediate secondary threat is severe hyperkalemia. The massive rhabdomyolysis floods the bloodstream with lethal concentrations of potassium, pushing the patient toward imminent cardiac arrest. Managing this requires a dual-pronged approach. Clinicians administer calcium chloride or calcium gluconate to stabilize the cardiac membrane, paired simultaneously with intravenous insulin and dextrose to drive the free potassium back inside the cells. Profound mixed acidosis must be managed concurrently. This is treated by sustaining hyperventilation and administering targeted doses of sodium bicarbonate, guided strictly by serial arterial blood gas measurements. There is an absolute pharmacological contraindication during an MH crisis. Administering calcium channel blockers to manage arrhythmias alongside dantrolene triggers fatal cardiovascular collapse. Aggressively stabilizing the secondary metabolic fallout is just as critical as halting the primary trigger. Failure to manage the potassium in acidosis will result in intraoperative cardiac death, even if the calcium leak has been stopped. Surviving the operating room does not mean the crisis is over. The patient now enters a period of prolonged vigilance in the intensive care unit, where a secondary crisis can strike without warning. This secondary threat is known as clinical recrudescence. It is the sudden, spontaneous recurrence of malignant hyperthermia symptoms after the initial successful treatment of the acute event. Statistically, recrudescence occurs in approximately 20% of all cases. The vast majority of these relapses happen within the first 16 hours following the initial crisis. To defend against this, postoperative protocols mandate continuing dantrolene maintenance dosing. Patients receive 1 milligram per kilogram intravenously every 4 to 6 hours for a minimum of 24 hours. Continuous serial laboratory tracking is mandatory. Clinicians most specifically monitor creatine kinase, or CK. CK is an enzyme that leaks into the blood when muscle tissue is damaged. Because of its delayed release profile, CK levels may not peak until 12 to 24 hours post-event. A patient cannot be discharged from the ICU until strict physiological criteria are met. Core temperature must be completely stable, acid-base status must normalize, CK levels must trend firmly downward, and myoglobinuria must clear. Following discharge, the patient's long-term pathway requires formal genetic counseling. Diagnosis of familial susceptibility is confirmed through RYR1 gene sequencing or the caffeine halothane contracture test, or CHCT. CHCT is an invasive muscle biopsy procedure considered the gold standard for diagnosing MH susceptibility. True mastery of malignant hyperthermia extends far beyond surviving the operating room. It demands vigilant post-operative defense and permanent familial risk management to identify the genetic trait, alter future anesthetic plans, and protect subsequent generations.